All right, we're rolling. Welcome back to the Low Carb Consultant Podcast. I'm excited to welcome back Dr. Jonathan Schoeff. Dr. Schoeff is a board certified general surgeon, longevity medicine expert, and co founder of the Longevity Lab in Greenwood Village, Colorado. In our last conversation, which was episode 22, so feel free to go back and check that out, we covered the fundamentals: diet, training, and metabolic health. Today, we're going deeper. We'll unpack the cutting edge of optimization medicine, hormone balance, peptide therapy, recovery compounds, and the science of building and maintaining elite health and performance. So I'm super pumped for this one. Dr. John, man, it's great to have you back.
Yeah, great to be here.
Yeah, and I was telling you before we started recording, man, I've been watching your content. I can see that you're growing. I just want to give you and your team a big kudos, because I can tell you guys are hustling. You got a good team behind you, but you're also pumping out some really solid, high value informational content to your audience. And for someone who's a content creator and a digital creator, I just want to tell you that I appreciate that. And I can see the information that you're putting out to people is just top notch. So I just wanted to give you and your team that kudos.
Thank you very much. I think the thing we committed to getting into this space was evidence-based, science-backed. Same thing we practice every day. Man, there's a lot of noise,
Yeah.
a lot of confusion. Some of it, I think, well-intentioned. Some of it goes off the rails. Right? Controversy sells. So I'm working my butt off just to provide quality information and insights.
And I can tell, and again, I appreciate that. I think you guys are doing a really good job here. And if anyone wants like your background, like I said, they should go back and check out episode 22. I want to jump right into things in terms of the optimization piece, the performance piece. I kind of want to just get straight into it. So when someone has already built like a solid foundation of health, how do you determine what comes next? Like, what separates being healthy from now becoming optimized?
Yeah. No, it's a great question. I think above all else, and this is, I mean, it's an overarching principle for what I do, hopefully what everybody does, data drives decisions.
Mm,
So there is so much subjectivity and so much misrepresentation around what is healthy. You know, if you're lean and ripped and you're the bodybuilder type, if you're the vegan, ultra critical about what you put into your body, does that make you healthy? Well, the question has to be answered by your own data. So looking at biomarkers, I think as a platform to define health and longevity, and then taking all the data we have and synthesizing it into really that overall picture of who the person is. But I think there is a lot of there are big heavy hitter topics that I think people just get totally lost in. That is weight management, lower weight, healthier.
mm.
Not necessarily. We talked about this before. It's
Body
all about
comp.
body composition.
Yeah.
So the biomarkers we choose have to be meaningful and actionable. I mean, I think that's problem number one. We're living in an era. I was on a call earlier this week where we are inundated with data, right? Direct to consumer has become a reality on every level. So you've got access to, me as a consumer, no health knowledge. I've got access to thousands upon thousands of biomarkers. I can order my own lab tests, right?
Mhm.
And then I can get my CGM. I can do my data. It's a good thing, I think, because we're just getting pummeled with data. The challenge is, what do we do with all this data? And how does the individual who's using their cool app that's bright and shiny object, but doesn't really provide actionable information? How do we take that and then turn it into real life, meaningful change, or looking at those opportunities for optimization? Does that make sense?
Totally. Totally.
So I think that um, it's one thing to get a bunch of data. It's a totally different thing to be partnered with someone who actually understands that data, can put it together, and then begin to talk about steps that would arguably move the needle the most for those data points.
For sure. And I've got some questions here in terms of the data and like the standard reference, the lab reference ranges in regards to,
Exactly.
what's what's standard and what is optimal in terms
Right.
of like the key biomarkers that you guys are tracking, like to decide if someone is a candidate for, let's say, like hormone therapy.
Hmm.
Like what does optimal really even mean? Like what does
Yeah.
optimal mean beyond the standard lab reference ranges?
Yeah. I mean, so I would ask you that. I would ask every client that. What does optimal look like for you?
Mm,
Where are the areas for optimization? Where are the kind of shortfalls currently? And then we need to take that information, what I'd term like subjective information. Hey, I'm fatigued. I run out of gas mid-afternoon. I have to take a nap. I struggle with focus. Maybe the libido's down. Hey, I'm in the gym, but I'm just flatlined.
yeah,
All those things, really that subjective feedback about who you are and where you want to go, that has to be the guiding principle for every decision. So now you're looking at a bunch of data points, a bunch of numbers in the context of that individual. And not everybody's the same. I tell people, yes, I feel like I can contribute most with my areas of expertise to someone that really is not satisfied with the status quo, with even good. They want better, they want best, you know? But that's not to discourage somebody who's okay with good, right?
sure.
So when
Interesting.
we
Yeah.
talk about optimization, it has to be in the context of that individual and where they want to go with things. But I think what you're alluding to and what is really important to understand is lab data is almost worthless
Mm,
in the context of normal. So there's a reason I get on some of my team about this. There's a reason that lab tests print out in color, right? Red, high or
yeah.
bad, green, good.
Yeah.
Okay.
Yeah.
It's meaningless.
Yeah.
It's totally meaningless. It is only in the context of that individual, right? Take testosterone. That's the easiest one to go after.
Sure.
Testosterone ranges for most US labs are somewhere in the 280 to 900 range for total testosterone. That's a
That's that's a
massive
large range.
window.
Yeah,
So
it's massive.
obviously, I don't think it takes a rocket scientist to say someone at 300 is not the same as someone at 890. They're both normal, but you have these broad population ranges that don't really apply to the individual. So, yes, I have in my mind where I think that good, better, best parameter lies, but it's still in the context of the individual and how they're performing and where are the areas to further optimize. So, every maybe not every, almost every client I meet with says, "Hey, I went to my doc. They said I'm normal." Right? That only means that you're in the green range,
Yeah.
which again is
Like, what does
I
that mean? Yeah.
another great example, Max, is yes, cardiovascular disease still the number one cause of death in the United States today. When you look at lipid profiles, what's normal today is radically lower than what was normal 3 to 5 decades ago. Okay. But furthermore, with a more clear and concise understanding of where risk factors impact on that, I look at different ranges for the individual. What are
Mhm.
your underlying risk factors? Is there a genetic component? Because your normal or optimized may be quite a bit lower when we talk about cholesterol levels than the guy standing right next to you who has a different genetic predisposition, right?
Mhm.
So these numbers, it's completely relative, and I think that's what AI and chatbots and applications, they can't get that nuanced because they're trying to target a broad-based population. And
Totally.
I'd submit that's where qualified physicians have their role in all of this.
Yeah, and so basically what I'm gathering from this is we can't go off these wide, massive reference ranges in terms of determining what is optimal for that individual. It comes down to that individual, what they're potentially deficient in, and then bringing those elements up as it pertains to them, their goals, and what they're trying to do, right? Would that be kind of like an accurate way to position it?
Absolutely.
Okay,
I'd simplify it to this. If three people walk into some practice, the low T center, for example,
sure.
and all three of those people walk out with the exact same thing, I would not go there
Yeah,
because
that's
this is a highly individualized, nuanced space that we live in, and it requires synthesis. I'll tell you this, Max, my new client consults, typically an hour and a half to an hour and 45 minutes. That's what it takes. Just like Max, if you and I sat down and talked just pure clinical about how do we get Max to the best version of himself, I got to know everything head to toe. I got to understand what makes you tick. What are your motivations? Where are you willing to make change? So on and so forth, right?
And to
But
be
that's the way you have to do it.
Well, and to be honest with you, that's a little refreshing to hear because I think typically, like historically in standard medical practices, you go in, the doctor only has 15 minutes. He goes
Oh, yeah.
down like, okay, how are you feeling? What are you doing? What are your blood pressure? Boom, here's a script.
Yep.
Like it's nice to know that you are literally spending that amount of time with the individual to gather as much data and information as possible about their life, how they live, what they eat, how they train, to
Everything.
prescribe the best protocol. That makes sense. That makes a lot
Yeah.
of sense. And in terms of, you brought up the testosterone piece a little bit earlier. Um, in terms of like testosterone, growth hormone, like how do you balance maximizing muscle mass and energy, or how would you balance maximizing muscle mass and energy without compromising like longevity down the line or other markers for an individual?
Man, that is the fine line we walk,
Mm,
right? I think here's the big picture of all this stuff is when you look at longevity metrics, I think the most impactful data is population data. Okay. So we observe, for example, that in the aging population, individuals with the highest skeletal muscle mass indices and the lowest, when they're compared, have an all cause mortality differential up to about 200%, 2x, right? That's an observation. Now, when we talk about biologic pathways, okay, the switches that get turned on for muscle growth, that's all driven by this mTOR,
mm,
MTOR pathway. If you're into this longevity, the biohacking, all that, you've heard of mTOR, okay? mTOR carries the moniker of like the anti-longevity pathway. Why? Because if you turn on the growth switch and you don't moderate that and it just goes, yes, there is the idea that that can be detrimental over time. What do we worry about? We worry about things like accelerated cellular decline. We worry about cancer,
yeah.
right? So you always have this yin and yang in the human body. And
Mm,
you know where I'm going with this, Max, is it's balance. Balance is everything. And I've come to really consider everything that I do in the form of, think of that kind of that traditional, the scale of justice, right? We live in a balance, right? mTOR activity chronically high, which does indeed, by the way, mTOR above all else is the anabolic gatekeeper. Okay.
mm,
So obviously we need mTOR turned on to build muscle. That's a fact. But there is evidence that mTOR that is overactivated or switched on too long might have detrimental effects. So it's constantly weighing the benefit and risk. Again, this is why AI doesn't cut it. It's way too nuanced. We've talked about this, the idea or the concept of periodization.
yes.
That to me, and Max, the last time we met, you made a point that was just rocked my world. You know, just look around you. We have seasons. And I was in the grocery store the other day and thought of you. I'm walking through there. I'm like, I can get strawberries year round, pretty good strawberries, right? I can get it. We really have access in this industrialized world to things that didn't exist before. We normally lived around seasons historically, right? So there's a fruit season, there's a meat season, there's a store. Now we live in a world where you can get anything you want. So now I think being smart about it, we have to periodize or create our own seasonal effect on whole body health. I know that's a bit of a ramble,
No,
but if you get where I'm going with it, it's
totally.
in everything in the human body. You mentioned growth hormone. That's another one, right? There in social media, it has to be black and white, yes or no, right? So you have the pro growth hormone, anti growth hormone. Pro growth hormone is all the benefits, connective tissue, wound healing, body composition management. There are incredible broad reaching benefits to growth hormone. Huge advocate. Then you have the anti growth hormone people that are like, If you turn on the growth switches, just like I said, and you just leave them on, ultimately that can become detrimental. Make sense?
Yes.
So this is why it's all so nuanced, because we have to be constantly looking at the interplay of all these biologic pathways and working to optimize the individual. But like I said at the outset, what drives the decision is, okay, we've got all these biologic pathways, this balance, everything going on, but what's the population data? Huge population data say. It says more muscle, longer, better life.
Yes.
So I'm going to consistently take that into consideration as we develop a treatment protocol. More time spent towards optimizing muscle health, I think, has long-term data to support. Same thing with VO2 max, same thing with insulin sensitivity.
Yeah, and what's really interesting, going back to what you were talking about in regards to periodization, eating seasonally, I've interviewed a lot of these people, like in the low carb, keto, carnivore
Yeah.
space, high fat carnivore space. And a lot of these people, I won't name names here, but I have some like returning guests coming on that were doctors
Mhm.
eating carnivore for a long period of time, and then they are ditching carnivore, right? And that kind of goes back to like the seasonal eating thing that you were bringing up, and just periodization. It's like the planet that we evolved on naturally has seasons, and we're
Right.
supposed to eat a certain way based off like where we're at geographically, what the food is available for us. Like there's a lot of
Sure.
factors that kind of go into that. But if it's like if you're on like a carnivore diet for some of these individuals, and you're on this diet for like extended periods of time, like it
Yeah.
works in the beginning, right? It works in the beginning because it's a massive elimination diet, and you can do a lot of things, but that diet is not necessarily meant to be done for years over years over years over years. And what we're seeing here is a lot of these doctors that I have interviewed are running into health issues, metabolic issues, lipotoxicity, blood
Yes.
marker issues, and they
Mhm.
have to get off the diet. Well, of course, that makes sense, because you're on a diet for a specific period of time. You're not supposed to be on the diet. You're supposed to be on the diet for a season, technically, essentially,
Yeah.
when you really think
Exactly.
about it. And then you got to basically, you don't necessarily have to eat seasonally, but you've got to be able to switch the diet up. And you also have to go through, I think, what you were talking about on the periodization standpoint. You've got to eat the right diet and then work out appropriately based
Yeah.
off of where you're at in a muscle building phase. And then you've got to like decrease the protein a little bit when you're
Yep.
when you're out of the muscle building phase, to give your body a break. And that's how you can naturally create this little ebb and flow over time, but
Right.
also consistently see progress. What are your thoughts on that?
It's you're 100% right. And yeah, unequivocally, this is my strong belief. Keto, carnivore, plant-based, they're all extreme positions on how you provide nutrients to your body,
Sure.
right? I live off of 5 key but very simple principles that are fluid amongst all these rigid diet parameters. But like you said, I mean, notwithstanding that, I hear these guys and they present data. Carnivore is an extreme diet. It's an extreme position. So is plant-based, by the way, if you're playing along at home. So we're comparing the extremes where
Yeah.
the reality lives somewhere in between. So yes, like you said, what is carnivore? I mean, the reason carnivore is so effective, you know why? Really, the reason is it's a sugar elimination diet. The problem with plant-based is there can still be an overload of sugar in a plant-based diet. Is that true across the board? Of course not. It's nuanced. But a carnivore-based approach to nutrition works really well for a metabolically deranged, carbohydrate dependent, obese individual.
Sure.
But it works very well for a period of time. So
100%.
my clients go through, and I mentioned this before, the reason I brought our entire advanced nutritional program back in-house instead of relying, and this isn't a knock on RDs or other nutritional experts, it's just what was missing for me is context. So when I'm giving people training programs, hormonal optimization, nutritional optimization, I'm taking into account everything instead of saying, "Hey, I'm your hormone guy. Go get this from elsewhere." And that's what radically changed really my approach to medicine, but also our client outcomes. Because now one person has oversight on everything. And I get grief about, well, I said this, I think before, but like, stay in your lane. You're a doctor. And I'm like, last I checked, I should be an expert in human health and condition. I mean, isn't that what a medical doctor is? I
Yeah.
spent almost 20 years in academic studies, very rigorous, understanding the human body, metabolic pathways, and all this kind of stuff. So, um, I personally believe that doctors should be the experts in everything human related. Now, if you want to bring me your cat, someone said this, they were like, I'd never bring my animal to you. And I'm like, that's very smart. I'm not a veterinarian. Those are called veterinarians.
Yeah.
As a medical doctor, I treat humans. So it's really critical that, and this is the challenge I see so many people facing, right? Because they're plucking data and information from this influencer and that influencer. But we don't, our body faculties and how the human body works, these pieces of the puzzle don't exist in isolation, in a silo. It's all interconnected. So yes, my position is, hey, if we're in a muscle building phase, we have everything locked in down to the supplements, down to the nutrient timing and sequencing to build muscle. Now I know population based muscle is medicine. Muscle will resolve metabolic dysfunction in and of itself. So do I push muscle health above some other? Yeah.
So
But it's not in to neglect the other elements of human health.
So I want to get into like peptide stuff, but since you brought up like muscle building, body composition, I say let's go there next. So, and I think
Do it.
this can also tie into what we were just talking about around eating seasonally slash periodization. So when someone's in a muscle building phase, how do you structure the optimization protocol, like in terms of hormones, maybe peptides, or
Yep.
nutrition?
Yeah. So, I mean, obviously this is very nuanced.
Sure.
Start with the data. Where are we at time zero? Define point A and understand what point B looks like strategically. Okay. Um, but generically speaking, I look at muscle health and optimization having sort of three key elements. First element is the environment in which the body's existing. And that's really the hormone health and optimization piece of the puzzle. Okay. Listen, if I could digress slightly, one of the most common situations I see today are younger and younger men presenting with lower testosterone.
Mm.
Why is that happening? Is it microplastics? No. I'd like to give that credit to the Paul Saladinos and all these like esoteric data points that probably move the needle collectively 1%, right? But the leading cause of low testosterone in reasonably otherwise healthy young men is metabolic disease. That is very clear and very obvious. Now add in central obesity, add in visceral fat mass. Specifically, visceral fat is an endocrine organ. We've always talked about it as, oh, it's just another element of fat. No, it's actually producing hormones. It's actually disrupting normal, healthy physiology. Visceral fat, insulin resistance, higher than normal levels of insulin and dysfunctional insulin receptors, right? And glucose running around in the bloodstream. That combo is lethal for testosterone. I would argue it accounts for probably 90% of the direct decline in testosterone. So I'm giving Saladino a lot of wiggle room here. We'll say 10% is made up of microplastics, detergents, and your freaking deodorant, okay? That's not the deal, right? I got people coming in, should I change my deodorant? No, you should lose the Goodyear tire around your waistline. We'll talk about the deodorant. So here's the challenge though, Max, is you have this group of individuals that fall into this metabolic dysfunction or metabolic disease category with low testosterone. Go back to the scale analogy,
Yeah.
right? Right now, the scale is severely tipped towards metabolic dysfunction. The best, most powerful tool I have to reverse metabolic dysfunction is muscle. So the key is, how do we build muscle in an environment that's heavily weighted towards metabolic dysfunction? You tracking?
Yes.
So this gets into the weeds of where do things like testosterone come into play? because
Mm,
and I want to break this out. If we've got time, let's get
sure.
into the weeds a little bit about what testosterone is, what optimization is, so on and so forth. But the challenge is these young men are being told, well, you're not eligible for any type of testosterone support because you're young and it could make you impotent. That's the general understand. That's the feedback I hear, right? But here's the thing. First of all, short-term testosterone optimization again, to shift the balance back towards muscle health is totally safe if done with a medical provider. And critical things like testicular preservation programs or protocols make impotence, certainly long term, really shouldn't be a risk. Shouldn't be something that I do talk about it with everybody, but it shouldn't really apply if these tools are used appropriately. And I consistently see this. Listen, I'm going to give you an outside source of testosterone. Shift the balance back in the favor of building muscle. Okay.
Yeah.
We're going to keep you on a testicular preservation protocol at the same time. So no long-term issues. And guess what happens? As you begin to build muscle, you're no longer climbing Mount Everest naked without a Sherpa. That muscle is metabolically active. You start reversing the metabolic disease. That's what's making your testosterone low in the first place. Men, the testicles kick back in, right? Then we can actually lower testosterone doses and may even convert them to something oral or nothing at all as they overcome that metabolic dysfunction. But
Interesting.
withholding testosterone for a young man who's obese, visceral fat, all these things I just listed, you're putting them in almost impossible position to succeed. Same as like the personal trainers that tell me like, oh, I'm all natural, I'm against this and that. Dude, if your client's testosterone is 250, forget about it. Now you're putting someone in a position where they're working their behind off
Yeah.
in the gym and they're not going to see results. The switch is off. So it's different. This is totally different. And this is where I'm going with this. Totally different than anabolic steroid abuse. Totally different. Night and day. We're talking about bioidentical testosterone. That has its own place in its conversation. The other issue I see and the controversy and the sort of public perception piece is testosterone, anabolic steroids, one and the same. Totally different.
Yeah. I kind of wanted to go back and touch on something
Yeah.
that you had brought up. So when we're optimizing someone, we get them up to, let's use the word optimal ranges for testosterone. And then you were almost saying, like, it sounds like to me, we could potentially almost reel back the dosing or the type that they're on, like go to an oral,
Yeah.
right? So I guess my question here in regards to that is like, what is almost like the, if you want to call it the recovery process, look like post
Yeah.
optimization? Like how can you, like, once you got someone up in terms of optimizing hormones, testosterone, and you get someone up to a certain level, how do you like restore balance, or how do you approach like the post optimization phase without
Right.
losing
Yeah.
that progress?
Right. So, I mean, we'll get into the weeds a little bit here,
Sure.
right? In the interest of the audience and everything, I'm not necessarily going to go um, dosing protocols and such.
Sure.
But I think the general principle is this. We'll say this: outside sources of androgens. Okay. So that includes bioidentical testosterone, anabolic steroid. All of the above suppress the body's normal testicular function, right? The hypothalamic pituitary gonadal, HPG axis. Okay. So I'm not here to tell you that anything of the sort does not interrupt that axis. However, we can maintain direct testicular stimulation and indirect through the HPG axis with a couple things. HCG, human chorionic gonadotropin, is a direct testicular stimulant. Okay, it's what we would call like an LH mimicker. It activates the LH receptors in the testicles, stimulates testosterone and sperm production. Okay, so we've got HCG, subcutaneous injection. There's something called gonadorelin, which is a peptide, very effective, actually arguably more potent than HCG. But when we shift gears to talk about peptides, a lot of the challenge with peptides is their half-life, what we call pharmacokinetics. How long does that injection stay in place? And
Mm,
gonadorelin, to get the benefits, has to literally be run continuously through a pump. So it's not practical. Okay.
interest, interesting.
So whereas HCG has a much longer half-life. It exists in the body longer. So we can inject it 2 to 3 times a week and have a nice steady state stimulation. So HCG is a powerful tool. And then the clomid in clomiphene, so clomiphene and enclomiphene,
Yeah.
okay, that family, something called SERMs, selective estrogen receptor modulators, are another powerful tool or powerful agent that sort of that works more centrally and tricks the brain, we'll say, that HPG axis to think, hey, we got to pump out more LH, luteinizing hormone, to stimulate testicles because that feedback mechanism is interrupted by the substrate, clomiphene or enclomiphene. Real quick, I haven't used Clomid or clomiphene in my practice for probably 7, 8 years. Enclomiphene is,
The oral
we'll say
form.
it,
It's an oral form, right?
well, they're both oral, but the difference is enclomiphene is just, I use this a lot in my practice, we'll talk about, but it's the cleaner version, right? No real side effects, no estrogen buildup, no secondary metabolites. It's just enclomiphene is not commercially available. You have to get it through a compounding pharmacy.
Yeah.
But that's all I use. So much, much, much more potent. So for perspective, Max, if you came to me and really important asterisk here is you have to have intact testicular function. And I define that by a baseline total testosterone above 350.
Okay.
So if you're below that, your production is too low to really see any benefit from enclomiphene. And I do combine enclomiphene and HCG. But if your body's producing testosterone, that protocol by itself, we can see a 300 to 350% bump. Huge, huge. I can take a guy with low, moderate testosterone and we can get into the range, we could get well above 1,000 for
Oh, wow.
perspective.
Oh,
Now,
wow.
this is
Just with
total
enclomiphene?
testosterone. What's that?
Just with enclomiphene and
Yeah.
HCG? Wow.
The combo is just ultra potent, right? Because you're tackling. Now, long term, there's probably an impact on receptor health, right? We can oversaturate. So you have to moderate these doses, but it is a very effective strategy that I use. So I feel very confident that if we suppress testicular production of testosterone and clomiphene, or excuse me, testosterone and sperm, we can easily come back and restart the engine. For example, a lot of things, traditionally when I started my own protocol with a doctor, they told me you're not eligible for exogenous testosterone. My natural production was about a little less than 300 total.
Got
This
it.
was in my early 30s.
Oh, wow.
So if you don't think stress and diet can really powerfully impact, I don't think it was my deodorant. I'll just be honest. But they said to me, I hadn't had kids yet, and they're like, are kids in the future? Yeah, it's malpractice to give you testosterone. That was what was told to me, and obviously I went with it. So I started Clomid HCG. This was quite a while ago, and it had a positive effect. I tell clients today, listen, it's no problem to use outside sources of testosterone, injection testosterone. We need to know if you decide, hey, we're going to have another kid, I need 6 months notice and we'll transition you to an enclomiphene plus or minus HCG regimen to ramp up natural production and specifically spermatogenesis, the production of sperm, healthy sperm.
Yeah.
My clients have no problem. The list of clients I have that are on injection testosterone as a primary protocol and then still conceive, we have 100% success rate. It's just not an issue. But if you're in the setting of like a low T center where they're seeing 1,000 people a day, no one's getting to that level, right? It's just all or nothing.
Yeah. I had a quick question here in regards to potentially bringing in different protocols and maybe where the line here is in terms of health optimization and enhancement. Because for me, I feel like, there's like this invisible line there that even for myself, like sometimes I question like where it is and if I'm interested in crossing it in terms of,
Uh-huh.
just messing around with just basic peptides that I get prescribed through like Merrick Health. Like I do my blood work through Merrick Health, basically
Yep.
based off what I'm deficient in, what my goals are, what I'm trying to do. They recommend different peptides. So I've taken like sermorelin, I've taken BPC, and I want to talk to you about some of these peptides
Yeah.
here in a bit, like
Sure.
BPC 157. I've taken pentosan. I use glutathione. So like I want to get into a lot of this stuff with you.
Yeah.
But I was
Yeah. Yeah.
curious in terms of like where that line is for you. And it could be patient dependent. But like how do you define the line between we're optimizing this guy or like we're over on the enhancement side, if that makes sense.
Okay.
Like the maybe the performance enhancement side.
Sure. Sure. Yeah, I mean, let's just be black and white.
Sure.
We're going to talk if you want to. We need to talk about anabolics and synthetic. This is really important. Synthetic anabolic steroids, right? Chemical compounds made in a lab, chemically created. Now, typically based loosely off of testosterone as a central molecule, but then chemically modified to have significant anabolic muscle growth effects, right?
Hmm.
There's no such thing as a pure anabolic. I take this and all that happens is muscle. There are some interesting things on the horizon, like myostatin inhibitors. That's an interesting, which we could get into. But as it stands today, when we talk about synthetic anabolic steroids, every one of those has a profile of anabolic and androgenic. Androgenic being all the things we associate with sort of the negative effects of high testosterone. Short fuse, short temper, some restless sleep, skin changes, whole body. You've seen the guy at the gym where you're like, yeah,
Yeah. Yeah. The
I know
acne
what's
on the
happening here.
back. Yeah.
Right. So that's anabolic steroids. And then we have very important to understand is bioidentical testosterone therapy. Real quick, yes, bioidentical testosterone is precisely that. It is the exact same chemical molecule that your body makes, that your testicles make. Okay. The only difference is that we use testosterone esters. We add a small chemical component to the testosterone molecule that actually is modified in the human body
Mm.
back to testosterone. Okay. This is not anabolic steroids. What your body is seeing is bioidentical testosterone. The ester gives a time course that allows slower release of that testosterone into the bloodstream. Okay. That's all it is. It is the same molecule, plain simple. Synthetic anabolic steroids, not at all the same. Is that cool?
Yes.
So going back to muscle health optimization versus enhancement. I believe, and what I would say I espouse is optimization, plain and simple. Now, to me, optimization is max benefit with fewest to no side effects.
Mm.
Okay, so the fewest category is where it's a little gray. So what, Max, are you willing to tolerate to achieve optimal performance? If you lose a couple hairs, are you okay with us adding some minoxidil to protect your hairline? Okay, so mild side effect that's manageable. If you develop some acne, are you okay with taking, for instance, like a Minicin and doing some topical washes to manage that, right? If it's manageable, I can consider that still within the optimization category. Does that make
Interesting.
sense?
No, it makes sense. And if I can lay out my own personal um qualms, I guess you could say. One of the reasons why, so right now I'm 40, right? And I have the option to, for sure, basically whenever I want through the people I consult with at Merrick, I have the option to go on like exogenous testosterone.
Yeah.
One, because my levels were pretty low when I got them tested. They well, again, I was lower on like the lab reference range, but I think I was like when I
Yeah.
originally tested, I was like 450 or something
Yeah.
like that.
Okay.
So it's like on the lower end,
Sure.
not where I'd like to be, let's say.
Right.
One of the main issues that and the things that have held me back the most is losing hair. Like, I just don't wanna lose hair because I feel
Yeah.
like and
Yeah.
that might be and from everyone that I talk to that is on, like, TRT, they say and some of them have lost hair, they say
Yeah.
the benefits and how you feel with regards to taking TRT, it's worth losing the hair. In my opinion, I just don't know if I can agree with that because,
Yeah.
like, I feel like, a big part of, like, looking and feeling young is having hair on
Yeah.
your head.
Yeah,
And I just
for sure.
don't know if that's a route that I want to go down. I'd love to get
Right.
your 2 cents on that. Or
Yeah.
is that maybe like a misguided way to think about TRT? Am I being like unreasonable?
No, no. So I get accused of I think over communicating
Sure.
sometimes. Um, my job is to educate my clients and empower my clients to make the decisions that are in the best interest of their own health. That's I'm a consultant.
Yeah.
The idea to me, doctor patient implies someone who's sick and someone who's telling you what to do. That's not the role I play. But it's a great question, Max. And the reason I was shaking my head is, Max, this is my perspective on that. It's unacceptable for me to say I'm going to optimize you for performance, but you're just going to have to accept some downside,
Mm,
whether it's acne, hair loss, unwanted hair growth, so on and so forth. Okay. So the real issue is this. What's very clear when it comes to testosterone optimization, higher levels, more risk. But the other factor we have to consider is how those levels are being augmented. The body deals at very well at a steady state. That's what it's used to. The problem with outside sources of testosterone is if they're not dosed appropriately, you wind up with these curves, which are a high spike and then a drop off, high spike. So when you're having those massive swings, that's where you see the complications. Hair loss, I just want to tackle that because it's a huge issue. And I'm I know what you're saying because like when I was in my 30s and stuff, hair, it just grows, you get a haircut. Gets in my 40s and I start looking at other guys going, man, that guy's got a good head of hair, right?
mm.
That's just real. Maybe it's vanity. So I'm with you. So I would tell a client, no, that's unacceptable. Hair loss is absurd. Okay. We need to implement a strategy to do one of two things. One, be monitor closely. And if we notice any changes, we take action. Okay. That's more for the guy that's like, yeah, I mean, hair's nice. No. But then there's guys like you, Max, that are like, no, this is an actual deal breaker for me. Right. So I'm looking at you going, but Max, you would benefit profoundly from testosterone. My job is to eliminate those side effects.
Interesting.
Right.
Okay.
So for someone like you, I would empirically put you on minoxidil and a hair optimization protocol. We can optimize your hormones. Let's optimize your hair health, right?
I love it.
So, so I would put you on oral minoxidil. There finasteride. We can get into Propecia, finasteride, DHT inhibitors,
Sure.
but I do that all topically. I don't want that systemic, right? Because I want to take advantage of the anabolic effects of DHT as well. Okay.
Interesting. Okay.
So the thing though is, uh, yeah, I hear guys say that, but they usually say that because they were never educated that this isn't an inevitable consequence, right?
Yeah.
People are like, yeah, I feel so good on my testosterone regimen, I can accept a little hair loss. No, no, you should feel maxed out on your testosterone and never have to worry about hair loss. That's just bad medicine.
Yeah, well, that's to be honest with you, that's a little comforting and refreshing to hear. I'll for sure like take that into consideration because it's like, so basically what you can, it's almost sounds like you can have your cake and eat it too. Basically, when it comes to
Of
increasing
course.
testosterone, but not having to like put yourself at the risk of losing the
No,
hair.
you just have to, I mean, that's why I go through this long list of things and say,
Yeah,
what are the deal breakers for you and how do we work around that?
got it.
At a testosterone 450, you would definitely be a good candidate for enclomiphene as well.
Yeah,
We really want to crank that enclomiphene plus HCG, right? So you got to just know what are our options and what are our priorities. Injection-based testosterone is still hands down the most direct means to an end. It's instant optimization. That's why I like it, right? Another question comes up just along those lines is, well, am I on it for life? On the one hand, I'd say this. I've never had a client come in who we optimize and who's like, man, I feel so good, doc. I want to stop everything. I-
yeah, exactly.
okay. But I have clients that say, hey, doc, I have concerns about being on this long term. What can we do strategically? Well, we're going to create, guess what? Periods of time
Mm,
where we crank, testosterone's optimized for muscle health, right? And in which case, so this goes all the way back to how we do this, but environment, I mean, the top three anabolic agents in the human body are testosterone and anabolic derivatives. Insulin is actually number two. And then insulin-like growth factor, which is a byproduct of growth hormone. IGF-1 is what's implicated in sort of that anti-longevity pathway. because guess what it activates? mTOR. So those are the three anabolic hormones. We need to get those right and address metabolic dysfunction. And we've got you off to the races, principally. So that's your environment. You've got to have the building blocks. That's your diet. Okay. At least a gram per pound, very aggressive. And then the last piece is the stimulus, right? If you have those two in place and you're not cranking in the gym, you're wasting potential side effects or downside with no benefit. So,
No, that makes tons of sense here. And real quick, I want to do a quick time check here because I know we're coming up
yep.
here on time, and I want to be respectful.
We've got, let's knock it, man. It's just hard because,
I
dude,
know.
these questions are, it's fascinating, man. It's fascinating. The world we live in, and this goes to again, I told you this, I think 5 months ago, I did not have an Instagram login, TikTok, those kinds of things. Okay.
Yeah.
Totally naive. It's like I've opened Pandora's box. You get this, right?
Yeah.
I mean, all of a sudden, and then, the algorithm is just now pumping out, like, do this in the gym, don't do that, lift it, and a lot of talk about anabolic steroids. Some, I think, is fair representation. Most is just off the wall crazy. And it still begs the question to me, ultimately, when you talk about synthetic anabolics, you have to understand the risk profile. And this is really clear. This is what I would say above all else. Okay. Here's the difference. Why do I say testosterone is totally different? Okay. Testosterone optimization, outside source of testosterone, like testosterone cypionate and anthenate, clearly does not increase the risk of cardiovascular disease and atherosclerotic plaque. Okay. Anabolic steroids absolutely do increase the risk of heart attack, something we call cardiomyopathy. They are very cardiovascularly toxic.
For sure. We're seeing bodybuilders drop dead all the time.
Night and day difference. I'm not going to say the recent wrestler who passed away, but it begs the question. So totally different in their impact on lipid levels. Yes, testosterone can trend towards a relatively worse lipid profile, but in a very manageable way. Whereas synthetic anabolics, terrible for liver health and also for lipids, cholesterol levels. Okay.
Mm-hmm.
So very distinctly different. Does that make sense?
Totally. Before we get into the rapid fire question segment of the podcast, I got one question here for you in terms of like what's coming down the pipeline, things you're excited about, like what maybe new compounds, peptides, diagnostic tools are you most excited about right now that are coming down the pipeline?
I mean, if we're in the muscle health category, without a question, it's the monoclonals, the what we call myostatin inhibitors.
Mm-hmm.
I think they're going to have an unbelievably high abuse potential when they get into the hands of the wrong people. The data is very intriguing. Myostatin, we talked about the balance. Myostatin and follistatin are basically the yin and yang of muscle growth. Myostatin inhibits muscle growth. So guess what? By the way, it's considered a longevity agent in that it turns off that just constant growth cycle. But imagine if you can have a targeted therapy that really shuts down myostatin. Now you've got unchecked growth. So the bodybuilder world's like, oh man, bring it on. And yes, the data would suggest that it has a much better risk profile on the whole than synthetic anabolics. So I would say that's the most intriguing thing. It's being used right now in conjunction with GLPs, and really powerful. The GLP plus semaglutide or Ozempic, GLP in the form of Ozempic plus trevoramab, which is a myostatin inhibitor, have demonstrated a 50% reduction in loss of lean muscle. So very, very powerful.
Wow.
And again, in that context, they're trying to make stuff that's going to inhibit the muscle loss and promote fat loss preferentially. That's where we're going with it.
Very cool.
I'd say that's definitely number one. And it's in phase 3. There are a couple in development, but they're in phase 3 clinical trials. So it will be, I imagine, on the market soon.
Very cool. All right. I got some rapid fire questions here for you that we can
And Zach and Max, the only thing I was going to say too.
Yes.
Totally fine either way. But I know you wanted to talk peptides.
Yeah, you know what? I did want to talk peptides real quick. I just wanted to be kind of
Yeah,
respectful of, what I know we're coming up here on time and I didn't
for
want the
sure, for
podcast to
sure.
go too over,
Yeah,
but if you did have time real quick,
yeah.
because I
I
did
think
want
it's a
to I did want to ask you about this because like I mentioned earlier, I played around with a bunch of different
yeah,
peptides. I've noticed some
right.
benefits. I've also not really noticed anything. Um,
Yes. Yeah, yeah,
peptides like excuse me, peptides like BPC 157, TV
right.
500, pentosan are, making the rounds here and becoming popular. Which ones actually move the needle in your
Yes.
opinion?
Yeah. I mean, so I think you got to start with a clear definition of what are peptides, because peptides by themselves, they're just short chains of amino acids, cell signalers, basically cell messengers. Unlike hormones that turn all these switches on in different cell types, peptides are a little more directive. Okay, that's the general definition, right? So that includes everything from growth hormone to some of these other tools that we're talking about. But yes, there are BPC by far and away. I see the most content about and the
Mm.
most dramatic presentations. Okay, what? So, and I kind of caught that list you gave me, and I think it's interesting. So so I'd say hot buttons right now, BPC 157. What is it? Body protecting complex, a naturally occurring peptide synthesized by the stomach. Saw a recent Peter Attia podcast post that was absurdly inaccurate and again very disappointing. When you
What did
veer
he
off
say?
course,
What did he say out of curiosity?
oh, so he said that BPC is actually what's called a VEGF, vascular endothelial growth factor
Okay.
analog, which is absolutely not the case. Now, BPC does seem to have some links or synergies with VEGF, but VEGF is in the same family as platelet-derived growth factor. There are a lot of growth factors that move around in the body. Platelets, think of PRP, is one mechanism to deliver large quantities of growth factors. Okay. But the moral of the story is BPC is not a VEGF analog. What it does seem to do, it does seem to magnify the effects of VEGF largely through angiogenesis, new blood vessel formation, which is key for healing. What are
Mhm.
we pushing BPC for? Everything from gut health, right? Improving the integrity of the gut lining to connective tissue injury and repair to new blood vessel formation. So the challenge here with peptides, I'll just say overarching, is that I think it's kind of twofold. One, um, they're completely unregulated. That's just the truth of the matter.
Sure.
We can't sugarcoat that.
Sure.
Now, do I believe that the FDA is an honorable institution? No, I do not. However, what the general public needs to know about the freaking FDA is they create standards. And that is in the best interest of the public. You cannot have an FDA approved agent that hasn't gone through rigorous testing, safety and efficacy. Okay. Whereas in the peptide space, there's zero oversight,
Yeah.
right? Now that the FDA stepped in and tried to regulate things like BPC, we're not going to get into the politics of that, but they're highly unregulated. Okay. And they lack scientific evidence. So again, does that mean they don't work? No. Does that mean you should proceed with caution? Absolutely.
Yeah.
Okay. So let's break down like what's out there. Again, the BPC is, I think, a top-notch one. And I use a lot of BPC in my practice, okay, especially around time of surgery. I'm very transparent with clients when I say, listen, there is some intriguing, what we call preclinical or animal data around BPC, just the things I listed off. Okay.
Yeah.
There is no substantial body of evidence for human use. Okay. So there's a gap. What I tell people anecdotally, I've used BPC myself, and there are positive reports with people using BPC. Could that be placebo? Yes.
Sure.
I will tell you
Sure.
this, Max. I do not ever use BPC outside of the combination of GHK, what we call sort of the glow stack, if you will.
Sure.
BPC TB500, which is a short chain version of thymosin beta 4. It's not the same. And then GHK copper. Put that together. A lot of skin benefits.
Yeah.
Okay. But I don't ever use the combination of BPC and TB500 without a growth hormone optimization protocol. So
Uh,
in truth, in fairness, I simply, maybe that's me saying I don't trust it in isolation, or I only trust it in the context of optimized growth hormone as a basis. Growth hormone overlaps all these benefits we just talked about,
sure,
right?
sure.
So I use recombinant growth hormone, which is just growth hormone synthesized in the lab. And then I use growth hormone releasing peptides, GHRP. You mentioned somorelin, ipamorelin, tesamorelin. Now, the most important thing I can convey here is that of all the peptides on the market, the most well-studied and human evidenced beneficial peptides are the GHRPs. If you were going to choose a class, unequivocally, the ipamorelin, tesamorelin category is as legit as it comes. Decades of positive human evidence, right? So tried and true, rises to the level of quality information. GHRPs work. So of those, I do not use somorelin at all because
Okay.
it's such a weak analog. Ipamorelin, tesamorelin, and then what I use a lot of for my high performers is the combination of tesamorelin and ipamorelin, which seems synergistic on paper. I'll say that. Okay. So I use a lot of that because basically understand tesamorelin is directly agonizing the GHRH receptor. So it's increasing production of growth hormone. Whereas ipamorelin, what we call like a ghrelin mimetic, is actually releasing that, stimulating a pulsed release of that increased production of growth hormones. Very
Interesting.
synergistic. Yeah, and
Interesting.
we see profound benefits from that combination. It is injection based, sub-Q. So that by far and away is a workhorse. BPC, again, I like it, especially for my high performers. Someone's going into again this intense muscle building phase, optimized growth hormone, and I think there's a role for BPC, but it's anecdotal,
Yeah.
and that's what I tell people. But then you start really getting off the beaten trail.
Yeah. Yeah.
So Cardilax, the cartilage repair peptide, really has no proven benefit. Pentacin is not actually a peptide, but there is promising data there. So pentacin as a cartilage healer, so to
Hmm.
speak, or cartilage stimulator, is actually being developed for human use. There are some phase 2, phase 3 clinical trials that are ongoing with
Hmm.
promising evidence. So I think pentacin, while it's not technically a peptide, is the legitimate um, potential option with
Interesting.
human evidence that's emerging.
Good to know.
Cardilax is another peeing in the wind phenomenon. Zero evidence. By the way, there's this whole preponderance of, you'll see it out there, okay? Russian evidence,
That's
right?
what
The
I've heard.
Russians
Yeah. Like
were
Cardilax is the Russian one, right?
correct. So Cardilax, some of these bioregulators, like testosterone, um, that it's a real stretch from reality. It's a real break from reality. And it kills me when they're like, oh yeah, but the Russians have investigated. There's great evidence, right? A peptide company told me that in a post.
Yeah.
Um, and they literally said, we've translated 2 of the papers. And like, I'm pretty sure Google Translate can get you all the papers. If it was real evidence, okay, the Russians do unique things. I'm not being critical, but they do unique things.
Yeah.
When you tell me there's Russian evidence that you magically cannot translate to the English language, it simply means to me there's no evidence.
Yeah. Well
So,
said.
so there are a variety of these things. But again, what I'd hone in on is, of all the peptides, if you're talking peptides, it's GHRPs, 100%, top notch, top of the list, best human evidence. Then we kind of scale to, again, EPC, TB500. They haven't risen to the level of human clinical evidence, which begs the question, why not?
Yeah.
Right? Because the people that are producing peptides are making tens of billions of dollars off this thing.
Sure.
So it's not like they're poor.
Yeah.
They could very well afford to do a study, just like Big Pharma does, right? So we have to beg the question, why not? And then again, you get into some of these even more far reaching. The other piece of the puzzle with peptides is there's a lot of theory And there's a lot of, again, preclinical data, meaning single use or single mechanism processes. But the challenge with peptides is the human body doesn't exist on like has this biologic pathway, right? Everything is interconnected. Switches are on, off, dimmer switches are involved, so on and so forth. So when you examine something in a lab and see some biological activity, or better yet, what most peptides are is working in reverse. Say, hey, I observe this thing having a positive impact on the body. Let's figure out what kind of amino acid chains we could synthesize. They don't really deliver in real life that same way. And that's evidenced by the human response. MOTS-C is a big one, right? I hear people talking about stacking MOTS-C. It's a mitochondrial enhancement. It's an uncoupler, so on and so forth. The fact of the matter is we simply just don't see changes in BMR, which would be, basal metabolic rate, which is prerequisite to claim that you're having a metabolic stimulative effect, right?
Yeah.
So I hear a lot of people, MOTS-C, SLOOP is another one, BAM15, they are theoretically valuable or beneficial, but they don't prove out in just real-time data. And my challenge to every guy out there, this is all I'll say, Max, anybody in the peptide space, if you're making money off of other people by counseling them to use peptides, okay? One, you are giving medical advice,
Yeah.
plain and simple. You're profiting off of the delivery of that medical that medical advice. If you are serious about helping people, which everybody claims they are, analyze the data, be transparent about where the true risk reward lies based on the data today, and also evaluate, at least bare minimum, evaluate these tools on yourself. If you're telling me something increases your resting metabolic rate, which by definition a mitochondrial uncoupler has to do, it's easy. You do a breath analysis, RMR, then you take your product, then you do another RMR. If nothing's changed, you can't look someone in the eye and say, this works.
Yeah.
It doesn't work that way.
Agreed.
So that's my overarching feeling. Yes, and we can come back to this too. We can do a whole peptide because it's fascinating. But as a physician, I'm not profiting off the sale. And I could go out and say, oh, all these peptide stacks. But again, all you're talking about is theoretic mechanisms without human benefit. So that's the challenge in the peptide space.
Interesting. And well said. And what's funny is, just for the sake of time here, I was going to jump into the rapid fire
Yeah.
question
Yeah.
portion. First question right out of the gun here. Most overrated peptide.
Most overrated peptide right now, I
Yeah.
have to say BPC 157.
All right.
As much as I think there is potential benefit, okay, just what I already said, BPC 157, so much social media attention and hype. First and foremost, by the way, oral BPC, no evidence for bioavailability. Okay. So it needs to be injection based. Okay. I believe in it. I have seen anecdotal benefit, but we've got to be really honest about what it does. Because I think it's just blown up on social media as like a fix all, this does it all, right? And that just simply is not evidence based. That does not mean there are not potential benefits, but it does mean proceed with caution, right?
Yeah.
So that's really any magic bullets out there, you gotta question. The human evidence is lacking. And like I said, in my practice, I always combine it with a growth hormone analog. So I know that works tried and true. And I, as a physician, am not willing to just do BPC 157 alone without being combined with TB500, without being combined with a GHRP for that reason.
Makes sense. Most underrated marker for health and longevity.
Oof. I think it's two, and they both deal in the same category. I think it's apolipo-B and lipoprotein little a. There's no secret that more Americans die of cardiovascular disease every year than any other single medical condition. Now, the driver I still strongly point to is metabolic disease, is insulin resistance and the progression of type 2 diabetes, because we look at that data and type 2 diabetics carry a 2 to 4x risk of a heart attack.
Okay.
That says it's impactful. But apolipo-B is a much higher resolution analysis of total lipogenic, or excuse me, total total plaque risk burden. Unlike LDL, Okay. The lipogenicity of ApoB is much more universal. Okay. So I think it's a critical marker, easy to get, cheap test. And then lipo(a) is that asterisk in the story of cardiovascular disease, because it is the other, we think, other primary genetic risk component to heart attacks that is otherwise not identified with traditional methods, like looking at total cholesterol, LDL. Okay. So these are the people who have high lipo(a) are the people that drop dead in the grocery store that
Yeah.
look like you, Max. They're fit and they have an underlying genetic predisposition to cardiovascular disease. What do we do with those people? Well, we shore up risk. Hey, you have a known genetically transferable risk for heart disease. We need to get your ApoB even tighter
Yeah.
controlled. So those, I would say those are the two workhorses. We should be checking them universally.
Well said. Um, this might be a hard one for you to answer. If you could only optimize one hormone for life, which one would it be?
In the hormone space, it's insulin without question,
Interesting.
right? We want to go to sex hormones, this and that.
Yeah.
If look at the converse, optimize insulin. What does insulin resistance look like? It looks like a 2 to 4x increase in risk of cardiovascular disease. It looks like a 3x increased risk of dementia. It universally, insulin resistance and the progression to type 2 diabetes is killing more Americans every year than any other single health hazard. So even though optimizing sex hormones may optimize muscle health, so on and so forth, at its core, if you are metabolically flexible, if you're metabolically healthy, you invariably will live longer. So I'd say insulin.
I think I agree with you, actually. Um, Last one. What compound do you personally use and swear by?
Give me a little more context. What
Whether it be
you
a
said compound?
peptide, yeah, whether it be a peptide, whether it's like exogenous testosterone, whether any sort of like outside compound
Okay,
peptide
yeah,
that you feel like you mentioned HCG a little bit earlier.
right.
Curious to
All have a
see.
role. I always say this, the universal, put in the supplement category, universal muscle health agent, which talked about the value of muscle, creatine.
Really?
I'd say that's the one thing every single person in the world today, minus maybe someone with kidney transplant or severe kidney disease, that's a gray area, but otherwise healthy, every single person should be on creatine. Muscle health, brain health, hugely impactful. If we're benefiting muscle, we're targeting that insulin issue, right? So when you put it all together, the one thing, because again, like I said, I go through cycles of growth hormone, I go
Sure.
through cycles of higher and lower testosterone. All those are moving parts. Insulin should be, or excuse me, creatine should be a constant.
Mm,
No reason we shouldn't be taking 10 grams, by the way, 10 grams a day. Yes, 5 grams is what's studied for muscle health. The pilot study that done in Alzheimer's patients, maybe 6 months ago, used 20 grams of creatine and showed significant improvements in the characteristics and in diagnoses of dementia.
yeah.
So you have 5 and 20. I land at 10 as a happy medium. But to be clear, because when people get all bent out of shape here, no, it is not evidenced in the literature. Newsflash, the literature is already outdated when it's published. We got to take into account, I think, brain health, 20 grams, optimal, 5 grams for muscle, meet in the middle.
Sure. I would
So
agree with that.
creatine, hands down.
Wonderfully said. Dr. John, man, this is awesome. Like, I appreciate your time. Where can people find you online, get in contact with you, work with you, all that good stuff?
Yeah, follow me Instagram at John Schoeff. You'll spell out my name. Important. There's no H in it. JONSCHOEFF. TikTok at Dr. John Schoeff. We're bringing long form video. It's a long time in the making. Our YouTube channel is about to really, I think, transform from the short form, rapid hit information to maturing that information and giving more direct guidance for people that are really interested in pursuing longevity. And then our website, longevitylabwellness.com.
Do you guys already have the YouTube? Because I'm going to put all this stuff in the show notes. Do you guys already have the YouTube like up and
Yep.
running, or is that coming down the line?
It is right now. It's dominated by short form.
Okay, got it.
But what we're starting this coming month is longer format
Got it.
or more rich information, the stuff you can't knock out in 45 to 60 seconds. But I
Yep.
think that really matters for these conversations you and I are having. These are nuanced conversations. They're not black and white. And I want to start really hammering those nuances from strictly from a medical perspective and providing that support for people who really want to move the needle, but it's just not enough to say yes, growth hormone, no growth hormone, yes, testosterone, no. That these topics are involved. This is why I love connecting with you, Max. Is getting into the weeds of this stuff where people can really begin to process, take into consideration the breadth of what's out there.
Hmm.
So yeah, that we were goal is to launch long form format YouTube channel in November.
Very good. Well, no matter what, I'll just put a link to the YouTube channel like in the show
Yep.
notes, and then obviously
Awesome.
the long form content we'll get there at some point. But no, that's really cool that you're doing that. So excited for you on that front. All the content that you're putting out, like highly suggest. I'll put your Instagram handle in the show
Yeah.
notes. I highly suggest someone just go to your feed on Instagram and just scroll through. Like you could just learn a lot, and especially in regards to what we were talking about here. So,
Yeah.
yeah, put all that in the show notes. This was awesome, Dr. Chef. And, for you guys listening to the Low Carb Consultant Podcast, we'll catch you guys on the next one.
Thanks, Max. Good to see you.